in women where the conservative management of stress urinary incontinence has failed, surgery to correct the stress urinary incontinence is an option. Stress urinary incontinence surgery, however, is not without its risks because it's an invasive procedure. There's several factors to consider, and one must give attention to, number one, the correct diagnosis, as there is different kinds of urinary incontinence. Are you finished with your family? As child labor can influence the pelvic floor and influence the further outcomes in future regarding your urinary incontinence. And the final factor being is that surgery to correct stress urinary incontinence will do only that. So in scenarios where there's mixed urinary incontinence, the stress component will be addressed, but the overactive bladder component will persist. It is not without its risks, and especially after the surgery, one can experience either difficulty in passing urine, an inability to completely empty the bladder, the sensations of urgency, or the unmasking of an overactive bladder, urinary tract infections, and then difficult or painful intercourse. The procedures to address stress urinary incontinence consist of retropubic bladder suspension procedures or a tension-free sling procedure. The retropubic bladder neck suspension procedures falls in the realm of the pelvic organ prolapse group and should be addressed there. The tension-free sling procedures consist of a procedure where either a synthetic mesh or tissue, your own homologous tissue or donor tissue is used to create a hammock below the bladder pipe or urethra. This causes significant scarring, with the end result that during episodes of stress with either sneezing, movement or coughing, the bladder pipe is prevented from opening. With all the procedures, you are admitted to the hospital and the procedure is performed either under a spinal or a general anesthetic. With the retropubic tension-free sling procedures, the incision is made in the vagina as well as 2 incisions in the suprapubic space. A needle is guided through the retropubic space with positioning of the sling, and the vaginal epithelium is closed either with an absorbable suture, the suprapubic incisions either with glue or a suture. A transobturated tension-free tape follows a similar principle as the retropubic suspension procedure. However, the incisions are made lateral to the labia with a needle using a tract used to position the sling. The final is a single incision mini sling, where a single incision is made only in the urethra and the sling is positioned. In all 3 procedures, the sling is not attached, but we rely on your own tissue to keep the sling in position. Your doctor may suggest a recovery period of between 2 to 6 weeks, depending on factors, your own physical factors, as well as surgical factors. As a rule, one would abstain from heavy lifting or strenuous exercise for between 2 to 4 weeks. One would refrain from sexual activity for at least 6 weeks after the sling surgery. Normally, one is discharged either the same day with the mini or less invasive mini sling procedures, but with the retropubic and transobturated tape procedures, a catheter is placed in dwelling with a vaginal tampon to decrease the risk of retropubic bleeding. On removal of the catheter the following day, if complete bladder emptying is present, the patient is normally discharged.